At the outset, I would like to thank Chaitra for including me in this prestigious IC today, where we can see so much of crowd out here. So I'm going to talk on something which is a very common problem, and we face a challenge every time once there is a question of doing cataract surgery. But I'm only talking about progression. There are other things which... we are all aware that there is a progression of diabetic retinopathy after cataract surgery, and it is much more if your surgery is prolonged, complicated, or even if you have, of course, more inflammation. So two things are very well known for a long time. Breakdown of blood-retinal barrier. It happens in every cataract surgery, as well as some inflammation that is also there. That's how you always, if somebody is telling me there is no progression at all, perhaps, I don't know, I doubt that. I don't do cataract surgery. Last I did was in '97. So this is something we learned from a very old study, which very convincingly showed, this was a multicentric trial, where you can see if there is a moderate or a severe NPDR, you're going to have just a jump as far as the worsening is concerned. So you should concentrate on this. But if you have a mild, maybe only 1% would have a worse vision. So it's very, very important. Look at here these figures. And is it dated? No. You have some evidence coming exactly now, very recently, from this large study done in UK. And you see exactly same findings. So if you have moderate to severe NPDR, you're going to have worsening. And you have to be very, very careful, and that's the way it goes. I'm going to show you some of these slides, dated slides of a laser era, 20/80 vision here, and so underwent surgery. It is less than 660. Patients are very unhappy. That is what happens all the time in these cases. This is from the laser era. Again, pre-cataract surgery like this, post-cataract. I'll show you some example just to convince you how it progresses very fast. And this, of course, after doing some lasers, this did improve and improved very well to 20/80. I would like to show you another case. I remember this lady who, after cataract surgery, she progressed, and the vision, and this is even, you can see that older time domain OCT there, and after laser treatment, this is before anti-VEGF. I'm showing some of these things to you. So what should be done? There are so many things which we need to learn, and the most important, which I'll talk in the end, is going to be talking to the patient. Or perhaps if you have a moderate or severe NPDR, and if you are not a very confident cataract surgeon, send it to your friend, because he's going to lose his practice, because it is definitely going to worsen. That is the way it is. So that happens all the time, and because we work in a large institution. So any longer surgery, and we also knew that in the era when we had even intra and extracapsular cataract surgery, the incidence was much higher. With very good phaco, with the modern where everything is sort of under control, I think we can do much better. And so what should be done in these cases? What should be done? I think we are not even giving. We feel, why should we give drops in the post-operative period? They'll stop very fast. I don't know why they want to do that. But don't do in the cases of, you see, it is inflammation. It's breakdown of the barrier. Give them more frequent, both steroids and whatever other agents you are giving, whether it is a bromophenol or nefrophenol, for a longer time. If you do that, maybe you will help them much better. So that's what is very important. I'll just show you this case here. Now you can see there is obvious evidence that whosoever did surgery, there's some irregular pupil, some kind of this thing organized fibrin there. And that's how the vision came down to 618, and a young patient. And look at the other eye. There was some cataract. The vision is still 6/9. Very unhappy. I remember she was referred to us somewhere from Haryana. And you look at this, hardly there's anything. And left eye, not only the DME has worsened, there's a PDR. So sometimes you have a situation like this. and you have a retinopathy behind, which is quite severe. You may have a posterior polar cataract, which is always a challenge, and if it's going to, and unrecognized sometimes or recognized, hard nucleus. Again, you're going to have more inflammation, more breakdown, or a pseudo-exfoliation. So you need to be an excellent surgeon and take all things and do everything possible. I have shown this slide many times. I remember this lady. This is way back in 2004. This is the right eye. Left eye underwent cataract surgery. This eye is perception of light. I have shown only the fundus of that. That is the pre-op and post-op. It ultimately went to neovascular glaucoma. So that is what can happen. That is where the problem is. So we know there is a big paradigm shift as far as the cataract surgery is concerned. We used to wait. We were not in a hurry earlier. Maybe we used to laser them well, then take up. Now we take up for early cataract surgery because we are giving, maybe we give 1 week prior, we give few days prior to cataract surgery, anti-VEGF or steroids. Also, what was shown from our center, if the patient can afford, you can give something like Ozurdex right there on the table, same time, and that works very well, which is also approved as far as Ozurdex is concerned. This is one such example where there was a lot of things have been done. Grid laser, 3 triamcinolone, and after, you see, intraoperative DEXA implant along with phaco, you have a result like this. This is already published in ophthalmology and it was very well cited. So what should be the recommendation? Basically, achieve first very good control. Don't jump at surgery. Perform excellent, be an excellent phaco surgeon, otherwise send to your friend, because I'm telling you, you're going to lose your practice. Pre-op or per-op intravitreal, Avastin or Lucentis, triamcinolone Ozurdex or whatever you want to give, is definitely going to make a difference. So that is what is very important. And so what I would like to say, always inform the patient, talk to them repeatedly. I tell them, well, you're going to be worse than what you have, but we have to remove that cataract because we can't treat you otherwise. So don't get worried about that. They question you all the time. But if you don't convince them, patient is unhappy, you are also with an unhappy patient. And especially I mentioned about moderate and the severe NPDR. Remember, if it is there, you need to do everything possible. And the post-op treatment should be aggressive and prolonged, as I said. Don't do what you are doing. You are great cataract surgeon, they are not here. There's no great cataract surgeon here, perhaps. They are all in a different hall. But they should give a longer time. And treat DME before and after cataract surgery aggressively. That's also very, very important with anti-VEGF steroids, because they do well if you have done a good surgery. But if it is a bad surgery, I think we land up into, so you really need an experienced cataract surgeon. I want to just add one last thing here. If you have DME, don't use multifocal, or tell your friend, if you use multifocal, I'm going to be very unhappy with you, so will be the patient. Because this we are seeing, somehow we want to, I think, I'm not talking about cataract surgery in DME, but I'm mentioning this one thing last. Thank you very much.